Welcome back to Radonc Smart Review Thoracic Edition. Picture this. It is 5 p.m. on a Friday. Your pager goes off, right?
Oh, it's a Friday at 5.
Exactly. And the emergency room has a lung cancer patient with this severely swollen face, engorged neck veins, and just a terrifyingly large mass on their CT scan.
Yeah, a total nightmare scenario for a trainee.
Right. And the primary team is demanding, they want you to fire up the linear accelerator and just start radiation immediately. So what do you actually do?
Well, you're really walking this tightrope between two massive opposing failures in that moment.
Yeah. And today we're tearing through a huge stack of sources. The latest astro-palliative frameworks, interventional pulmonology guidelines, the AJCC version 9 staging manual, just to build a foolproof mental model for you.
Because in that high-stakes 5 p.m. consult, the first mistake is the one everyone naturally fears, which is moving too slowly, right?
Right. You hesitate while a critical system, like a central airway, a major blood vessel, maybe the spinal cord, is actively collapsing.
Exactly. You wait around for the perfect pathology report while the patient literally loses the ability to breathe.
But I'd argue the second mistake is actually far more common in our field. And it's fueled almost entirely by panic.
Oh, absolutely. Treating the scan instead of the patient.
Right. You move so fast because the imaging looks so terrifying that you rush a totally stable patient to the machine and just deliver empiric radiation.
And by doing that, I mean, you might permanently destroy the only viable biopsy site they have.
Exactly. You obscure the true stage of the disease, and you lock a potentially curable patient into a strictly palliative path.
Yeah, that's the core paradox here with thoracic emergencies. The true skill of a radiation oncologist isn't just, knowing how to draw a target volume.
Yeah, it's holding both of those realities in your mind at the same time.
Right. An unstable patient needs immediate, aggressive escalation. But urgency does not automatically mean radiation is the correct first move.
No, not at all. Sometimes it's central, sometimes it's adjunctive, and a lot of times it shouldn't happen at all until a mechanical procedure does the heavy lifting.
Yeah, so let's ground this in reality for the listener.
Good idea. Let's use a foundational case from the literature stack to anchor the logic today.
Okay, lay it out.
So you're called to the ER for a patient presenting with a newly identified bulky central thoracic mass. They're complaining of progressive dyspnea.
Pretty standard presentation so far.
Right. You walk in and you see noticeable facial and neck swelling, plus those classic, prominent superficial veins mapped across the upper chest.
So the contrast CT is strongly suggesting superior vena cava SVC obstruction.
Exactly. But here are the vital clinical details you observe at the bedside. The patient is uncomfortable, definitely anxious, but they are speaking to you in full, coherent sentences.
Okay, that's huge.
Yeah, and they're oxygenating at 98% on room air. I don't hear any stridor. There's no confusion, no fainting or syncope, no focal arm or leg weakness, and their blood pressure is completely normal.
And the crucial missing piece here, I'm assuming, is they have no prior history of cancer and no tissue diagnosis yet, right?
Nailed it. Zero tissue.
Yeah.
Then the ER doc taps you on the shoulder and it's just like, so, are you taking them to the vault to start radiation tonight?
Oh, man. The pressure in the room is just immense in that exact moment.
So how are you answering that? What do you say?
I'm looking the ER physician directly in the eye and saying, no, we are not radiating tonight.
Wow, just a hard no.
A firm no. And if you're pressed to defend this, in a tumor board or on your oral exams, you have to explicitly state that while this patient has symptomatic SVC obstruction, their actual real-time physiology is completely stable.
So what is your immediate move then?
I mean, my immediate move is to elevate the head of their bed, optimize supportive care, and proactively alert the vascular and pulmonology teams just to have them on our radar.
Sure, just getting the gears turning.
Exactly. But because the patient lacks a tissue diagnosis and is maintaining their vital functions, reflexively delivering empiric radiation tonight is, well, it's a severe medical error.
Wait, okay, I have to play devil's advocate here for a second.
Go for it.
I'm looking at a scan where a massive tumor is actively crushing the main vein, returning blood from the brain, right? The patient's face is visibly swelling. Why isn't this an emergency? Like, why is it dangerous to just shrink the tumor right now?
Because you were treating the CT scan, not the physiology. We have to separate anatomical distortion from physiological failure.
Okay.
If we deliver 30 grays of radiation to that mass tonight, we trigger massive cell death and necrosis.
Right. Which sounds good in theory, but...
But fast forward 3 days, the pulmonologist goes in to get a biopsy, and the pathologist gets a slide full of dead, unreadable sludge.
Oh, wow. Yeah.
We won't know if this was a highly treatable lymphoma or, a small cell lung cancer that would have just melted with chemotherapy.
Or a non-small cell lung cancer with an ALK or EGFR mutation.
Exactly. One that could have been controlled for years with a daily pill. By panicking and treating without tissue, you might have just robbed that patient of years of life.
That makes a ton of sense. So to answer the consult question properly, we have to completely detach ourselves from the drama of the imaging and really interrogate the patient's actual bodily systems.
Precisely. The intent of our treatment has to dictate the timing.
Yeah, and palliative intent is just such a massive, messy umbrella term. I mean, it could mean we're trying to stop an imminent hemorrhage today.
Right.
Or it could mean we're trying to give someone durable local control of an airway mass so they don't suffocate 6 months from now.
And the mechanism we choose has to match the time horizon of the threat. The foundational question we must ask is never, what radiation dose should I use?
Okay, so what's the first question?
The first question is, what specific physiologic system is failing, and how many minutes, hours, or days do we have before it collapses entirely?
Let's build a mental checklist for you, the listener, to categorize these threats rapidly at the bedside.
I love checklists for this stuff.
Yeah, when I review the literature on oncologic emergencies, it really boils down to 4 distinct domains of instability. Let's call them AV&R.
AV&R, airway, vascular, neurologic, and respiratory.
Perfect.
Okay.
If you can systematically clear the AV&R domains, you can confidently tell the primary team that the patient is stable.
Okay, let's start with A, airway.
Yeah, I know we look for stridor, but what is physiologically happening to cause that?
So stridor is that high-pitched, turbulent whistling sound, and it is a massive red flag.
Yeah, it sounds awful when you hear it.
It does.
Yeah.
And according to Poiseuille's law of fluid dynamics, airflow resistance is inversely proportional to the radius of the tube to the 4th power.
Oh, wow, the 4th power.
Right. So that means if a tumor cuts the airway radius in half, the resistance to breathing doesn't double. It increases by a factor of 16.
16. That is wild.
Yeah. If you hear stridor or see a patient drowning in their own unmanaged secretions, or watch their accessory muscles heaving just to pull a single breath, that airway is on the absolute brink of total occlusion.
And if I see that, I am definitely not scheduling a simulation appointment for tomorrow morning.
No, absolutely not.
I am calling anesthesia or interventional pulmonology for an immediate rescue.
Okay, let's move to vascular and hemodynamic instability.
Okay, so in our SVC case anchor, the patient was stable.
Right. So what does an unstable vascular patient actually look like?
An unstable vascular presentation means the mechanical obstruction is now compromising end organ perfusion.
Okay, so we're talking about blood flow to vital organs.
Exactly. We are looking for syncope, which means they're fainting because venous return to the heart is so poor that cardiac output has just dropped.
Right. Or altered mental status.
Yes, confusion, indicating severe cerebral venous congestion. The brain literally cannot drain its blood.
Terrifying.
Or, outright hemorrhagic shock from massive active arterial bleeding. Right. Which brings us to end neurologic instability. I feel like this one gets dangerously overshadowed in thoracic cases.
Oh, it gets missed all the time.
A patient comes in coughing up a little blood, the whole team fixates on the lung mass, and nobody bothers to ask if the patient can actually feel their toes.
It really does happen. Neurologic instability in this context usually means epidural spinal cord compression.
So what are we evaluating there?
You're evaluating for new progressive motor weakness, a distinct sensory level where sensation just changes abruptly.
Right, or gait instability.
Yeah, or sudden loss of bowel or bladder control. The spinal cord tolerates ischemic compression extremely poorly.
So time is spine, essentially.
Exactly. If you miss this because you were too distracted by the primary chest mass, the patient could be permanently paralyzed within hours.
Man. Okay, finally. Our respiratory instability. Now, this is distinct from the upper airway obstruction we talked about with stridor, right?
Very distinct. This is deep within the lung parenchyma or the pleural space.
Okay, so what are the signs?
We're looking at a rapidly escalating oxygen requirement, severe hypoxemia despite supplemental O2, or acute ventilatory failure.
Driven by what, usually?
Often a massive pleural effusion just collapsing the lung, or a raging post-obstructive pneumonia.
Okay, so if the patient exhibits failure in any of those 4 AV&R domains, the pathway is immediate rescue.
Yes. And this highlights a massive semantic problem in our field. We constantly misuse the word emergency.
We really do.
An intern calls and says, "We have a radiation emergency." But what they actually mean is, "I want a same-day radiation simulation."
Exactly. I like to picture it this way, right? Taking a physiologically stable patient and rushing them to the radiation vault is like taking a sledgehammer and tearing open your living room drywall to fix a water stain.
Oh, that's a great analogy.
Right. You do it before you've even turned off the main water valve and before you've even bothered to check if the water is actually coming from a leaky roof instead of the plumbing.
Yeah, you're executing an irreversible, destructive intervention without understanding the underlying mechanism. And that analogy perfectly captures the biology of our modality. We have to remember how radiation actually works on a cellular level.
Right. It's not a laser beam that just burns things away instantly.
No, we are delivering photons that cause DNA double-strand breaks. Those breaks don't magically dissolve the tumor on contact.
The cell has to try to divide first.
Exactly. The tumor cell has to attempt to divide, realize its DNA is shattered, and then undergo mitotic catastrophe or apoptosis.
And that biological cascade takes time.
A lot of time. When we look at the data for palliative thoracic radiation, the median time to meaningful symptom improvement is roughly a week to 10 days.
So if a patient's going to lose their airway in the next 2 hours, a treatment that takes 10 days to peak is fundamentally just the wrong tool for the job.
Precisely. Now, returning to our SVC case anchor.
Right, the stable patient in the ER.
We cleared them. No stridor, no confusion, no syncope, no oxygen requirement. That bedside physical exam did an immense amount of heavy lifting.
It really did. It proved the patient can tolerate an expedited diagnosis-preserving pathway.
Exactly. So we have bought ourselves a window of time.
The big question for you is, what are we buying that time for? And the guidelines make it incredibly clear. We are buying the diagnosis.
We are entering the territory of the tissue mandate.
Yes, the tissue mandate. Why is it such a hard rule?
Because histology dictates the entire trajectory of the patient's remaining life. If we radiate blindly, we destroy the architecture of the tumor.
Right. We discussed how that ruins targeted therapy options, but it also alters the staging, doesn't it?
Oh, drastically.
Let's talk about that staging opportunism. If I'm holding off on radiation to let the pulmonologist do a bronchoscopy or let the surgeon drain a massive pericardial effusion to stabilize the patient, I need to make sure they don't just throw that fluid in the biohazard bin, right?
This is a critical error to avoid. Whenever a stabilizing intervention occurs, you must relentlessly advocate for tissue preservation.
Right. So if a pleural effusion is causing respiratory failure and needs to be tapped for immediate mechanical relief,
that drained fluid is a goldmine. Send it for cytology. Finding malignant cells in that fluid instantly changes the patient's disease to stage 4 under the AJCC version 9 criteria.
And a quick administrative note from the sources for you.
Yeah.
Always explicitly use the AJCC version 9 framework in your documentation.
Yes, please do.
A lot of legacy systems try to auto-populate older staging rules, and you just have to be precise.
Absolutely. Now, to navigate the tissue mandate efficiently, I always run through 3 specific diagnostic questions with the multidisciplinary team.
Okay, what's the first one?
First, is there already adequate pathology sitting in a lab somewhere?
Ah, right.
Perhaps they had a biopsy at an outside community hospital 3 weeks ago, and we just need to pick up the phone and request the slides.
I've actually seen that happen.
Yeah.
Everyone is scrambling to biopsy a dangerous lung mass, and it turns out a dermatologist took a punch biopsy of a weird scalp nodule a month ago, and it showed metastatic adenocarcinoma.
Exactly. It saves so much risk. Which leads to the second question. Is there a safer, more informative biopsy site than the central thoracic mass?
Oh, that's a great point. Sticking a needle into a highly vascular necrotic mass wrapping around the pulmonary artery is incredibly dangerous.
Very. So if the patient has a palpable supraclavicular lymph node or an accessible liver metastasis, biopsy that instead.
Right, because it provides the tissue diagnosis and simultaneously proves metastatic spread, which completes your staging in one safe move.
Exactly. And the third question is what we just touched on. Will the stabilizing intervention itself yield the tissue?
Right, like if interventional pulmonology has to go in to core out a bleeding tumor in the airway?
Yeah, they are essentially handing you the biopsy on a silver platter while they save the patient's life.
No, we must acknowledge the clinical reality here. There are rare extreme exceptions to the tissue mandate, right?
There are. If a patient is actively suffocating from a tracheal mass and no interventional pulmonologist or surgeon is available within 100 miles, and they are too unstable to transfer.
Yeah, in that case, yes, you treat empirically to save their life.
But even in pure chaos, You can practice opportunistic staging. You can draw basic tumor markers.
And you can ensure the pre-treatment CT scan is perfectly preserved and reviewed before the radiation radically alters the imaging baseline.
Exactly. Always preserve the baseline.
All right, let's take this foundational logic diagnose when they are stable, mechanically rescue when they are crashing, and apply it to specific anatomical crises in the chest.
Okay, let's go back to our SVC patient.
The scan shows severe compression of the vein. If they were crashing, or let's say they are confused and their blood pressure is dropping, what is the actual mechanism to fix that fast?
If the threat is mechanical pressure, the fastest rescue is mechanical radial force.
So a stent.
Exactly. Endovascular stenting. The interventional radiology or vascular surgery team navigates a wire across the compressed segment of the SVC and deploys a self-expanding metal stent.
And how fast does that work?
The moment that stent opens, the venous return to the heart is restored. The facial swelling will often visibly improve before the patient even leaves the recovery room.
That speed is incredible. And this perfectly illustrates why the radiation oncologist shouldn't act alone. The sequence is vital.
Right. Endovascular team places the stent for instant mechanical relief. Then pulmonology gets the tissue safely now that the venous pressure isn't sky high.
Then medical oncology runs the molecular markers.
And only then do we, as radiation oncologists, step in.
Right, we might deliver a durable local course of radiation to the mass to prevent it from eventually growing through or around the stent, assuming the histology isn't exquisitely sensitive to systemic therapy alone.
Exactly. It's a team effort.
Let's shift the anatomy slightly. What if the bulky central mass isn't crushing a vein, but is physically obstructing the right main stem bronchus?
Okay.
The patient has a severe wheeze, a post-obstructive pneumonia brewing behind the blockage, and their oxygen levels are starting to dip.
Central airway obstruction is a classic high-yield scenario. The critical radiographic and bronchoscopic distinction here is whether the tumor is intraluminal.
Meaning it's physically growing like a polyp inside the airway.
Exactly. Intraluminal versus whether it is purely extrinsic, just pushing from the outside.
Why does that distinction dictate our management so much?
Because it determines what interventional pulmonology can physically accomplish. If the tumor is inside the lumen, an interventional pulmonologist can use a rigid bronchoscope to literally core it out.
Right, they can use a laser or electrocautery?
Yeah, or argon plasma coagulation to vaporize the bleeding tissue, immediately restoring the airway caliber.
But if the tumor is entirely outside the airway, just pushing the tracheal wall inward,
then there is nothing inside the lumen to cut away. In that case, they might deploy an airway stent to hold the cartilaginous rings open against the external tumor pressure.
okay, I see where radiation fits into this puzzle now. If the pulmonologist clears the inside of the tube, but there's still a massive tumor bulk sitting in the mediastinum.
Radiation is the tool we use over the next few weeks to shrink that external bulk so it doesn't just crush the airway again later.
Right. So radiation is a terrible tool for acute mechanical clearing, but it is an exceptional tool for durable prevention of a recurrence.
Correct.
This brings up a massive pitfall, though. Let's say the pulmonologist goes in, clears a mucus plug, burns away some intraluminal tumor, and the previously collapsed right lung certainly re-expands.
Oh, this happens a lot.
What happens to the radiation plan we meticulously crafted yesterday?
It belongs in the garbage.
Just throw it out.
Literally, yes.
Yeah.
When a collapsed lung re-expands, the entire mediastinum, the heart, the great vessels, the trachea, physically shifts its position inside the chest cavity.
Right. The tumor itself might have been pushed 3 centimeters to the left.
If you put that patient on the linear accelerator and treat using the original plan, you are going to blast healthy functioning lung tissue and completely miss the target.
And that is the golden rule of thoracic emergencies for you. Post-procedure anatomy is fundamentally new W anatomy.
Say it again because trainees miss this.
Post-procedure anatomy is fundamentally new W anatomy. If they got a stent, if they had a lung re-expand, if they had a liter of fluid drained, you must bring them back to the simulator.
You have to get a new CT scan and verify where the critical structures are right now.
Okay, speaking of critical presentations, we have to talk about hemoptysis.
Yeah, a patient coughing up blood is one of the most terrifying experiences for both the patient and the physician.
Absolutely. It can range from just a few blood-streaked tissues in the morning to a catastrophic arterial hemorrhage that fills the lungs in minutes.
If a patient is actively hemorrhaging, again, radiation is not the answer. They need a definitive vascular procedure.
Usually, that involves interventional radiology threading a catheter and embolizing the bleeding bronchial artery, right?
Yes, but once the acute crisis is stopped, how effective is radiation at keeping that bleeding from coming back?
That's the key question.
And the data for hemoptysis palliation is actually remarkably strong. In older literature and modern prospective registries, palliative external beam radiation provides meaningful improvement or complete cessation of hemoptysis in roughly 70 to 90% of patients.
70 to 90%, that's excellent.
Yeah, the ionizing radiation damages the tumor vasculature, inducing endothelial swelling, microvascular thrombosis, and eventually fibrosis, which seals off those fragile, leaky tumor vessels.
That's a significantly higher success rate than we see for symptoms like chronic cough or dyspnea, right? Which tend to hover around a 50% response rate.
Much higher.
But before we just prescribe a standard palliative dose for bleeding, we have to play detective. I can't just look at the blood. I have to know why they are bleeding.
Absolutely. You must investigate the underlying mechanism.
What are some common culprits?
Are they on powerful anticoagulants for a recent pulmonary embolism? Is the tumor cavitating?
Oh, cavitary tumors are scary.
They have a high risk of catastrophic hemorrhage because the necrotic center can rapidly erode into a major pulmonary artery.
Right. Or is there a severe fungal infection, like an aspergilloma, living inside that cavity driving the bleeding?
Exactly. And the most important question of all, has this specific area of the chest been treated with radiation before?
Right. Prior radiation changes the math entirely. Re-radiation is a minefield.
You cannot simply guess or estimate the prior dose overlap based on an old clinic note. You must retrieve the actual historical dosimetry.
Because the spinal cord remembers.
The spinal cord has a hard biological memory. If you exceed its lifetime tolerance, you will cause radiation myelopathy, which is irreversible paralysis.
And the proximal bronchial tree and the esophagus are equally unforgiving, right?
Overdosing them can cause a massive fistula and abnormal connection where the airway and esophagus fuse, which is frequently fatal.
Let's move from bleeding to fluid, pleural and pericardial effusions. A patient comes in severely short of breath and the x-ray shows the entire left half of their chest is just a whiteout of fluid.
A symptomatic pleural effusion is a fascinating clinical entity because it solves two of our problems simultaneously.
How so?
It is the physiological driver of the dyspnea, and it is a massive staging opportunity.
Right, the thoracentesis.
A simple therapeutic thoracentesis, where a needle is used to drain a liter of that fluid, provides immediate mechanical relief of the breathing difficulty, while simultaneously handing us the fluid we need for cytology to confirm malignant spread.
But to be explicitly clear for you listening, as radiation oncologists, our target is never the fluid itself.
Never.
We do not draw a massive radiation field covering the entire pleural space just because it's filled with liquid.
Correct. The fluid is just a symptom. You have to find the factory producing the fluid.
So we look at the post-drainage imaging to identify the specific focal tumor mass that is obstructing the lymphatics or irritating the pleura.
And we target that focal mass to slow down the fluid production, while medical oncology and pulmonology coordinate long-term management, like an indwelling pleural catheter or a chemical pleurodesis to scar the space shut.
Okay, but what if that fluid is not in the lung, but wrapping around the heart? A pericardial effusion.
That requires hypervigilance. The pericardial sac is fibrous and doesn't stretch easily.
Right, it's pretty rigid.
If fluid accumulates quickly, it exerts immense pressure on the right ventricle, preventing it from filling with blood during diastole.
Cardiac tamponade.
And it is a rapidly fatal hemodynamic emergency. If you see hypotension, a racing heart, distended neck veins, or if the echo shows right ventricular collapse, radiation is completely off the table.
That patient needs an immediate pericardiocentesis by cardiology, or a surgical pericardial window to drain the fluid and save their life.
Exactly.
This brings us to a conceptual framework from the literature that I find incredibly helpful when deciding which modality to use. We can evaluate every intervention across 4 distinct dimensions: speed, mechanism, durability, and burden.
Let's break that down. Speed and mechanism are intimately linked. An endovascular stent provides mechanical relief instantly. Embolization provides vascular control instantly. Fluid drainage provides hydrostatic relief instantly.
And systemic chemotherapy acts systemically to attack microscopic disease everywhere. And for sensitive histologies, It can begin shrinking tumors in a matter of days.
And then there is radiation. The mechanism is biological DNA damage. The speed is delayed days to weeks.
But its massive advantage is durability.
Right. A short, well-targeted course of radiation can keep a tumor from reobstructing an airway for many months.
And finally, burden. Surgery might provide a definitive mechanical fix, but the physiological toll of general anesthesia and recovery on a frail, metastatic lung cancer patient might be too high of a burden.
No single modality wins all four categories. That is precisely why the sequence of intervention first, radiation second, is the gold standard for thoracic emergencies.
You use the fast, mechanical tools to stabilize the patient today, and you use radiation to provide the durable biological control that keeps the crisis from returning tomorrow.
Perfectly said.
Okay, so we've stabilized the patient, we have tissue, and we've determined that palliative radiation is the right tool to provide durable local control of the mass. The patient is on the simulation table. How do we choose the dose?
Well, I know the worst thing a trainee can do is rattle off a memorized reflex prescription without thinking.
Exactly. You never start with the dose. You start with the patient's goal and their realistic time horizon.
We are navigating a complex web of variables here. What is the performance status? Are they spending 18 hours a day in bed, or are they still walking around?
What is the biological pace of their disease? Do they have a critical cycle of systemic chemotherapy starting next week that we cannot delay?
What is the logistical burden of transportation?
That's a big one. If a patient lives 2 hours away and needs specialized transport, asking them to come in every day for 3 weeks is a massive reduction in their quality of life, especially if they only have a few months to live.
Exactly. So instead of a single dose, we think in terms of fractionation families based on biologically effective dose, or BED.
Let's look at the options. We have single fraction regimens, like 8 or 10 gray in 1 fraction.
We have short fractionated courses like 17 gray in 2 fractions or 20 gray in 5 fractions.
And then we have the protracted higher dose courses, like 30 gray in 10 fractions or 37.5 gray in 15 fractions.
The fundamental trade-off here is between the probability of durable tumor control versus the burden of toxicity and time.
Let's talk about the biological mechanism behind that toxicity. Why does a longer course like 30 gray in 10 fractions cause so much more esophagitis than a shorter course?
It comes down to the radiobiology of rapidly dividing normal tissues. The mucosal lining of the esophagus relies on a basal layer of stem cells that constantly divide to replace the surface cells that slough off.
Right.
The natural turnover time for that esophageal lining is roughly 7 to 14 days.
Okay, so if you give a 2-week course of radiation, that's 10 fractions, you are hitting those dividing basal cells every single day, precisely during the window when they are desperately trying to repopulate the damaged lining.
Exactly. The stem cells are depleted, the lining ulcerates, and the patient experiences agonizing pain when they swallow.
So for a frail patient with a short life expectancy, exposing them to 2 weeks of travel and severe esophagitis just to get a theoretical benefit in tumor shrinkage 6 months from now is just poor medicine.
Very poor. A shorter course like 20 gray in 5 fractions, or even a single 10 gray treatment, minimizes that acute mucosal depletion, gets them off the machine faster, and lets them resume systemic therapy.
But conversely, if you have a patient with excellent performance status who has an isolated symptomatic tumor that is bleeding and they're expected to live for several years on targeted therapy,
then a higher dose protracted course might be entirely justified to maximize the long-term ablation of those abnormal blood vessels.
whatever dose family you pick, you must obey the causality rule.
Ah, yes, the causality rule.
The physical mass you are targeting must be the actual mechanical or biological cause of the symptom.
Right. If the patient has unremitting dyspnea, but the scan shows diffuse lymphangitic carcinomatosis, meaning the cancer has infiltrated the microscopic lymphatic channels throughout both lungs, radiating one arbitrary 4-centimeter mass in the right lobe is not going to change their breathing.
Not at all. Or consider the patient with a main stem airway obstruction who is actively developing a post-obstructive pneumonia. Radiating the mass does not suck the infected mucus out of the lung.
No, they need bronchoscopy and antibiotics. Every radiation prescription is a causal claim.
You are stating, this specific anatomical target is driving this specific symptom, and my dose will biologically alter it in a time frame that benefits this patient.
Beautifully put.
Let's talk about the actual mechanics of treatment planning. There's this outdated assumption that palliative simply means fast and crude.
Yeah, a resident might think, it's just palliation, let's just do a simple APPA opposed pair of beams, draw a box around the tumor, and get it over with.
But the evidence actually points toward higher quality planning, right?
It does. We have to look at the landmark 2021 randomized trial investigating palliative central lung radiation.
Oh, I love this trial.
The investigators compared standard simple opposed fields against esophageal avoidance, intensity modulated radiation therapy, or IMRT.
But I can hear the pushback already from the community. IMRT takes longer to plan, it requires more physics QA, and it costs more. Is it really worth it for a patient who is just getting 10 fractions for symptom control?
The data says yes, particularly for the protracted fractionation schemes.
Right.
The trial demonstrated that utilizing IMRT to intentionally carve the high-dose radiation away from the esophagus substantially reduced the rates of clinician-reported symptomatic esophagitis.
Because when you use simple APPA fields for a central tumor, the radiation beam travels straight through the chest, hitting the tumor, but also blasting in the esophagus that sits directly behind it.
Exactly. IMRT uses multiple beam angles and computer optimization to sculpt the dose around the tumor while dropping the dose in the esophagus to a safe level.
The key caveat from the literature is that this benefit was most pronounced in the subgroup receiving the longer 30 gray in 10 fractions regimen, where we know the biological mucosal depletion is most severe.
Right. So the takeaway isn't that every single palliative patient must have IMRT.
The takeaway is that thoughtful conformality matters. If taking an extra 30 minutes to plan an IMRT field prevents a patient from suffering excruciating pain when they eat during their final months of life, that is a highly valuable intervention.
Quality planning also means understanding your imaging at the simulator. If a patient is actively struggling, you don't want to waste time, but you still need clarity.
Use intravenous contrast during the planning CT if their kidney function allows it.
Yes. Contrast is invaluable for visually distinguishing the actual solid tumor mass from a collapsed atelectatic lung or from the major blood vessels it might be invading.
And what about respiratory motion? We know lung tumors move when the patient breathes.
If the tumor is adjacent to the diaphragm and moving significantly, a 4D CT scan is necessary to capture the full envelope of motion so we don't accidentally miss the target.
However, we must balance quality with reality.
Always.
If a patient is actively hypoxic and struggling to lie flat on the hard simulation table, you cannot force them to undergo a 30-minute breath hold 4D CT protocol.
You get a rapid, free-breathing scan, add a generous margin for uncertainty, and get them off the table safely.
Let's talk about the hierarchy of planning priorities. When you are sitting at the computer, looking at the dose distribution, what is the absolute mandate?
The hierarchy is strict. Priority 1, deliver an effective dose to the specific symptom-driving gross disease.
You are not trying to prophylactically treat the mediastinal lymph nodes. You are targeting the mass causing the crisis.
Priority 2, absolutely avoid catastrophic injury to serial structures. The spinal cord cannot exceed its threshold. The central airway and major blood vessels must be respected.
And priority 3,
protect the remaining functional parallel organs. If the patient has a collapsed left lung, their entire life depends on the functioning right lung.
a dose distribution that looks perfectly fine on a generic textbook histogram might be fatal if it damages their only remaining source of oxygenation.
This brings us to the moment of treatment at the machine. The patient is lying there, and the therapists take a cone beam CT, or CBCT, to verify their position before turning on the beam.
I've seen situations where the internal anatomy has completely shifted overnight.
This is where image guidance is critical, and where simple bone alignment fails completely.
Right. If the therapist just aligned the patient's spine to the plan, but a pleural effusion has rapidly accumulated overnight, that fluid will have physically pushed the lung and the tumor 3 centimeters anteriorly.
If you treat based on the bone alignment, you will fire the high-dose radiation directly into healthy tissue and miss the tumor completely.
You must verify that the soft tissue target is actually inside your plant fields and that the spinal cord hasn't drifted into a hotspot.
And as the attending physician, you have to establish clear stop criteria for the therapists before fraction 1 is ever delivered. You have to document contingency plans.
What are the triggers that should cause the team to halt treatment and call you immediately?
The triggers are any sign of escalating instability. If the patient arrives for fraction 3 and reports new stridor, major hemoptysis, a sudden spike in their oxygen requirement, a new fever indicating a possible post-obstructive infection, or any new numbness or weakness in their legs, that is a hard stop.
You do not treat through that.
You pull them off the table, conduct a full clinical reassessment, and determine if they need a new acute intervention.
Let's transition to the follow-up logic. The patient finishes their short course of radiation and goes home. Palliative surveillance is tricky because we aren't following a rigid curative protocol. How do we monitor them?
You focus on the specific symptom you treated. Is their breathing easier? Has the bleeding stopped? But a major pitfall I see with trainees is declaring the radiation a failure too early.
Yeah. If a patient finishes a 5-fraction course on a Friday, and on Monday, the primary team calls to say the patient is still coughing, you have to remind them of the biological timeline.
The tumor cells are just beginning to undergo mitotic death. You need to give the radiation at least a week or two to manifest its primary clinical benefit.
But what if a month goes by and the dyspnea is actually getting worse?
Then you have to revisit the causality rule. Broaden your differential diagnosis. Don't just assume it's radiation pneumonitis.
Did the tumor progress rapidly because it's a highly aggressive histology?
Did the pleural effusion reaccumulate? Did they develop a pulmonary embolism because cancer patients are highly hypercoagulable?
A post-treatment CT scan is justified if it will actually change your management. For example, if it might indicate the need for a new stent or a change in systemic therapy.
It is not justified if the patient is transitioning to hospice and wants no further intervention regardless of the findings.
To crystallize this entire framework, let's discuss the specific traps and pearls we've covered. But let's frame it as the common mistakes we see people make when they are pressured in a tumor board or on their oral exams.
Okay, I love this.
The first major pitfall is panicking over a stable syndrome.
Yes. Treating stable SVC obstruction before obtaining tissue. The faulty logic is assuming that the word syndrome automatically implies imminent death. It doesn't.
If the patient is talking and breathing normally, throwing an empiric radiation field at them destroys their biopsy options and compromises their staging.
The correct move is to explicitly document their stability, clear the AVNR criteria, involve the endovascular team for potential stenting, and aggressively pursue the safest biopsy.
Another major pitfall I see is tunnel vision on radiation as the only rescue tool.
Using radiation as the solitary strategy for a mechanical emergency is a failure to understand mechanisms.
If a patient has a massive hemoptysis or cardiac tamponade, radiation is too slow and biologically inappropriate for the acute phase.
The correct logic is to match the mechanism of the intervention to the threat. You use embolization for bleeding, stents for compression, and drainage for fluid.
And you utilize radiation subsequently for durable local control.
And the final common mistake is choosing a fractionation schedule before defining the actual goal.
Just grabbing a standard palliative dose off the shelf is intellectually lazy.
A 10-fraction course has entirely different biological consequences and logistical burdens than a single fraction course.
You must justify your selection by analyzing the patient's prognosis, the depth of the symptom, the risk of nearby critical organs, and the patient's own transportation and caregiver support network.
I think we've built a really solid foundation. Let's put this logic to the test.
I want to run a few rapid-fire scenarios by you, just like we would if we were standing in the back of the room at a multidisciplinary tumor board. Let's call it the board blitz.
I am ready. Let's hear the cases.
Case number 1. We have a 65-year-old patient with a new central thoracic mass. They have facial swelling, dyspnea, and visible venous collaterals on their chest. The CT confirms SVC obstruction. We have no tissue diagnosis. The patient is sitting up, speaking in full sentences, maintaining oxygenation, and has absolutely no stridor, confusion, syncope, or low blood pressure. What is your fundamental management strategy?
My strategy revolves entirely around the fact that this patient is physiologically stable. They require urgent, expedited care, but they do not require reflexive, empiric radiation tonight.
Right.
I would immediately coordinate to obtain the safest, highest yield tissue diagnosis. If their symptoms become highly distressing, I would ask the endovascular team to evaluate for a stent to provide rapid mechanical relief.
You are holding on radiation.
I'm holding radiation in reserve until the histology confirms whether we need systemic therapy, palliative radiation, or perhaps even a curative multimodality approach. Treating without tissue in the stable patient isn't defensible.
Spot on. Okay, let's twist the scenario. Case number 2. Same patient. You are in the process of arranging the biopsy for tomorrow morning, but suddenly the nurse calls you to the bedside. The patient has developed a high-pitched wheeze stridor. Their oxygen requirement is rapidly increasing, and they are starting to look confused and agitated. What is your next move?
The clinical picture has radically changed. They have failed the AVNR criteria. They are showing acute airway and neurologic or cerebral vascular instability.
So the tissue mandate?
The tissue mandate is immediately suspended. Physiological rescue takes absolute precedence over an elective biopsy. I'm calling anesthesia or interventional pulmonology for immediate airway protection and mechanical decompression.
Will you still try to get tissue?
I will ask the proceduralist to grab tissue opportunistically if it is safe, but I will not let the desire for a perfect biopsy delay the intervention that will save them from suffocating.
Exactly the pivot required.
Yeah.
Last one, case number 3. A patient has a massive central tumor causing a right lobar collapse. We have tissue, the patient is stable, and we've determined a 5-fraction palliative radiation course is the perfect plan. We do the simulation scan, draw the fields, and the plan is approved.
Okay.
But before the first treatment, a pulmonologist goes in, clears the airway, and the collapsed lung completely re-extends. The patient shows up to the linear accelerator for fraction 1. The therapists take the daily cone beam CT and notice that the tumor and the heart have shifted 2 inches to the left compared to the original simulation scan. The therapist asks if they should just align to the spine and treat. What do you tell them?
I tell them to stop immediately and take the patient off the table. This is the golden rule in action. Post-procedure anatomy is new anatomy.
Period.
The lung re-expansion has caused a massive internal soft tissue shift. If we treat based on the original plan using bone alignment, we will miss the tumor and likely overdose the heart or the healthy remaining lung.
So back to sim.
The only safe move is to send the patient back to the CT simulator, acquire a new data set, and adapt the radiation plan to the new anatomical reality.
The framework we have built today is deceptively simple to summarize for you. Stabilize the failing systems, preserve the diagnosis when they are stable, precisely match the intervention's mechanism to the threat, and customize your dose fractionation based on the patient's unique goals.
Simple to say, but executing that logic at a 5 p.m. on a Friday takes profound discipline.
It really does. And I want to leave you with a provocative thought to mull over. As our targeted systemic therapies become increasingly rapid and our interventional tools like stenting and bronchoscopy become even more advanced and minimally invasive, how long will it be before the use of external beam radiation for acute thoracic emergencies is considered a crude historical footnote, reserved only for when absolutely every other tool in the hospital has failed?
That is a fascinating question. It forces us to constantly reevaluate our utility. We are no longer the only hammer in the hospital, which means we must be incredibly precise about exactly which nails we choose to strike.
Next time, we move from the chaos of these common thoracic crises to the nuanced complexities of uncommon anterior mediastinal disease. Get show notes and complete practice oral boards at radonsmartlearn.com and subscribe for our next episode. Thanks for tuning in.